in Johannesburg, and she's going to talk about management of sepsis in pregnancy. Dr. Mnyani, I hope you're able to share. Feel free to take over.
That's fine, Prof. I've put up my screen.
Yes, I can see it, and we put it there. That's it. Great, thank you. You want to put your video on so people can see you? That's fine.
I've put it on. Am I visible?
Not yet, but don't worry about it. You can proceed.
Okay. Thanks so much, Prof, and good morning to everybody. So as Prof said, I'm going to talk about sepsis in pregnancy. And just in terms of, Prof, I'm not able to advance the slides, not sure why. Oh, here we go, okay. So I'll just briefly talk about some of the definitions that we use and then focus on the burden of pregnancy-related sepsis, specifically in South Africa, and some of the risk factors that predispose to sepsis in pregnancy. Talk about assessment and management and levels of expertise. And then lastly, just talk about some of the missed opportunities in managing pregnant postpartum women that present with sepsis. So if we're talking about pregnancy-related sepsis, the focus is purely on infections in the genital tract or any tissues involved in the birth process. And the focus is on viable pregnancies. So the National Inquiry into Maternal Deaths in South Africa, if it's talking about septic miscarriage related infections. And a few years ago, WHO actually came up with the term of maternal sepsis. And this is defined as a life-threatening condition with organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or the postpartum period. And the important thing about this is that it includes both direct and indirect infections. If we look at data from our Saving Mothers report, looking at maternal deaths, the proportion might seem small, but pregnancy-related sepsis, which I've highlighted there at the bottom, is the 5th leading cause of maternal deaths in South Africa. And again, if you look at the trend from 2011 to 2017, the maternal mortality ratio related to pregnancy-related sepsis hasn't changed. And also, if you look at potentially preventable deaths, almost close to 80% of the deaths due to pregnancy-related sepsis, which is illustrated there with the red arrow, are potentially preventable. And if you look at levels of care, so community health centers there are represented by the blue bar. So in terms of avoidable factors, the majority of these occurred at higher levels of care, which were the district hospital, regional, and tertiary hospitals. And in terms of our province, pregnancy-related sepsis remains a priority condition because deaths due to pregnancy-related sepsis are 15% above the national average. So I've already given you the definition, and if you're talking about the upper genital tract, it may involve the endometrium, myometrium, operative incision, pelvic peritoneum, or the entire peritoneal cavity. And again, just to remind everybody that severe puerperal sepsis is life-threatening, and that as much as the focus is talking about the pelvic organs, sepsis can be and may be from any other organ involvement. Patients typically may present with low abdominal pain and or abnormal vaginal discharge, which may be foul-smelling. And some additional features, and just to remind everyone that secondary postpartum hemorrhage, which we describe as hemorrhage after 24 hours after delivery, may be a sign of puerperal sepsis. And it's easy to miss the early signs because of atypical presentation or incomplete assessment on admission. And I'll talk more about the importance of the initial assessment. And it's also, the assessment may be complicated by the physiological changes during pregnancy, which may predispose women to and aggravate their response to infections. So in terms of some of the risk factors, and to have a high index of suspicion if the patient presents with any of the symptoms that I've measured, so the patient has had a cesarean delivery, there's evidence of retained products of conception, prolonged labor and prolonged rupture of membranes, which is often accompanied by multiple vaginal examinations, traumatic delivery, and in terms of antenatal factors, the patient has had anemia, any immune suppression related to HIV infection, diabetes, or chronic use of corticosteroids. Also obesity, and then lastly, extensive vulvar warts. So the question is, can puerperal sepsis be prevented given all these risk factors that I've talked about? So I'll come later to prevention. So in terms, when you see a patient who's presenting and the suspicion of puerperal sepsis, the important thing that a detailed history is taken, and if the patient is accompanied by anybody, to get a collateral history as well. Full clinical examination, as I've mentioned before, because there may be other organ involvement. And bedside investigation has included there that it should include an ultrasound. And then the definitive management. So if you look at the sepsis guidelines, they always talk about the golden first hour of presentation and the importance of transferring to the next level of expertise for definitive management. So in mild cases, the patient will be fully awake and alert, will be apyrexial, there will be no tachycardia, blood pressure will be normal, and there may be mild uterine tenderness, but there won't be any peritonitis, and the lophia may be offensive. In cases of severe sepsis, patient will be pyrexial, and the most important indicator, and we'll talk about the SOFA score later, is that the patient will be tachycardic, and beware of a patient who's got a heart rate that is more than the systolic blood pressure. This is an indication of severe illness, and the other signs that I've talked about as well. And in the severe cases, there will be decreased level of consciousness. And the patient who's got decreased level of consciousness may present with restlessness, and I've talked about observations already, and you measure their oxygen saturation. And then in terms of organ system evaluation, so people talk about the big five, which is your central nervous system. And when you're assessing the central nervous system, you're looking at the level of consciousness. CVS, look at the heart rate and the blood pressure. Respiratory system, you're looking at the respiratory rate. Liver, this will talk to your liver enzymes, kidney, urine output, and any abnormalities in your urea and creatinine. And then there's the forgotten four, which is hematological. You look at the white cell count, you look at the hemoglobin, you look at the platelet count. And then the immune, we're talking here about the patient's HIV status, and we know this in our country, 30% of our pregnant women are living with HIV. And then endocrine refers to glucose levels. Musculoskeletal is saying, assess the patient if she has any deep vein thrombosis. Deep vein thrombosis, taking into account that pregnancy and the puerperium increases your risk of developing a deep vein thrombosis. And then in terms of your urogenital assessment, you assess the uterine size by doing a bimanual assessment, any tenderness. You assess the cervix, put in a speculum, look at the cervix, is the os open, can you see products, is the cervix pink, is the cervix blanching? And then again, the role of abdominal ultrasound. So if you're doing an abdominal ultrasound, you're really looking at, are there any products of conception inside the uterus? And with some practice and skill, you should also be able to say, is there any free fluid in the abdomen, particularly in the pouch of Douglas? And then it's important also to do blood cultures. Ideally, do blood cultures before you start antibiotics. But if you cannot do blood cultures, please do not delay starting antibiotics. And do a urine MC&S. You'll see as we talk later that UTIs are a common cause of sepsis in pregnancy and postpartum. And part of the initial management is to start IV fluid resuscitation, and the advice is that you run it at 125 to 240 mils an hour. Put in a urine catheter to monitor urine output. And in terms of choice of antibiotics that you're starting in the golden hour, remember we're starting empiric antibiotics that will cover both anaerobes and aerobes. So the recommendation is to start IV cephalosporin, third generation cephalosporin, or clindamycin, or ampicillin if you don't have the other two, combined with gentamicin IV and metronidazole, which can be given orally. IV formulation is not readily available and would really only be relevant if the patient is vomiting. So the aim is that if you are working in a community health center or in a district hospital, is that you stabilize the patient, and then the patient is transferred to the next level of expertise for source control. So the recommendation is that we talk about level of expertise rather than the next level of care. So as I said earlier, is that if the patient's heart rate is more than the systolic blood pressure, this is a sick patient. And a patient who's got a systolic blood pressure of less than 90 or heart rate of more than 100 is sick. And on top of giving IV fluid, you give oxygen and you monitor saturation. And the aim is that you raise your systolic blood pressure to at least 100 or a MAP of 65 or more, decrease the respiratory rate to less than 30, and maintain the saturation at more than 90%. If the blood pressure remains low despite giving fluids, you need to consider giving vasopressors and blood transfusion if the patient has bled and there's evidence of anemia. And again, as soon as the patient is stable, you transfer the patient to the next level of expertise. I've just put in a reference here from the Society for Maternal Fetal Medicine, which did a series on sepsis during pregnancy and the puerperium. And they talk about the quick SOFA score. Some people might be familiar with the SOFA score, which is the Sequential Organ Failure Assessment. And it has been simplified to say that you can do a bedside assessment to assess a patient who's critically ill. And it's really looking at 3 clinical criteria, which is a systolic blood pressure of 100 or less, respiratory rate of 22 or more, and if the patient's level of consciousness is decreased. And the quick SOFA score says that you have 2 or more of these criteria, the patient is at an increased risk for poor outcomes. And if you look at these 3 criteria, it's saying that fever is neither necessary nor sufficient to determine whether sepsis is present. And remember that if patient is severely ill, she may actually not be pyrexia, and especially our patients who are living with HIV who have significant immune suppression. So in terms of organ damage caused by sepsis, I've just put up a list here to say that with your CNS, there will be altered mental status, CVS evidence, hypotension with vasodilatation, myocardial dysfunction, which is where your vasopressors will come in, evidence of ARDS with involvement of the pulmonary system. Patient may have a paralytic ileus and a distended abdomen. Hepatic system we've talked about already. Urinary system. So the guidance again is that the patient should pass at least about 30 mL of urine per hour. And as I indicated earlier, that as part of the resuscitation, you should put in a urinary catheter. Thrombocytopenia and DIC is obviously an ominous sign that the patient is severely ill. Endocrine system, you check your glucose levels. And some of the common sources of infection, if you're assessing either a pregnant or immediately postpartum patient, is that obviously septic, abortion, endometritis, if a patient has delivered, whether she's had a cesarean section or had a vaginal delivery, chorioamnionitis, wound infection. And again, when we're talking about wound infection, if the patient's wound is septic, you always need to open the wound completely for it to drain, and obviously to assess if the sheath is intact. If the sheath is not intact, it means that the patient needs to have a laparotomy. UTIs, as I've talked about, is that with the initial assessment, you do a urine dipstick and do a urine MCNS as part of your initial evaluation. Pneumonias as well, appendicitis, and other GIT causes of sepsis. So in terms of the causative organisms, in terms of maternal sepsis, most frequently isolated is your E. coli, group A and group B strep, staph gram-negative anaerobic bacteria, and oftentimes you have a polymicrobial cause of the infection, which is why it's important that your initial management is giving an empiric broad spectrum antibiotics as soon as possible. And your blood culture will then help you to narrow your antibiotics and to check immune resistance. So after the antibiotics are started, culture is obtained, and then the next thing is that you must go and look for the source of infection and then do the source control. Obviously at the level where there is expertise available. Fluid resuscitation I've talked about. Importance of venodilatation in a patient with sepsis. And as much as fluid resuscitation is important, you need to be careful of risk of pulmonary edema because of leaky capillaries. And I'm just share with you here a publication from an assessment of the risk factors for septic death in South Africa. And this is looking at the period from 2014 to 2016. And they assessed whether clinical management was compliant with current guidelines in these cases of deaths due to sepsis. So their key findings was that hemoglobin was not recorded in 73% of the patients who died. And remember I mentioned earlier that anemia is one of the risk factors for pregnancy-related sepsis. Mid-upper arm circumference was not recorded in 68%. Again, obesity being a risk factor, meaning that there was a missed opportunity to screen patients for diabetes and manage those with diabetes. 79% of patients who had a cesarean section were not given prophylactic antibiotics. And this is standard guidelines is that before you do a cesarean section, routinely you give prophylactic antibiotics. And I'll talk about what the recommendations are. And the patients who presented and were septic, 77% had inadequate or no fluid resuscitation. Temperature was not measured in 39%. Almost half of the patients' antibiotics were started too late. Only about a quarter of the patients had cultures sent off. And alarming of all is that 28% had a hysterectomy done as source control. And remember, these were patients that specifically died of pregnancy-related sepsis. In terms of the recommendation for antibiotics, the recommendation is that you give third-generation cephalosporin And now there's also a recommendation that we add azithromycin as a stat dose. So the important thing about the cephalosporin is that it's obviously if the patient is obese, you need to adjust the weight accordingly. Also, if there's excessive blood loss or the procedure is prolonged in cases of complications, you need to give an additional dose. Augmentin has also been used in high-risk cases as part of the prophylactic antibiotics. And I've just put in here a study that was done in Tanzania, which actually showed that even if you give a single dose of ampicillin and metronidazole, it was enough to prevent post-cesarean section infections. So the other findings from the assessment of the maternal deaths who died from sepsis was that respiratory rate and a tachycardia and a low systolic blood pressure were very common findings in patients who died, and 88% had more than one abnormal vital sign. And obviously relevant in our country is that more than half of the patients who died were HIV positive. 71% were on ART, and again, more than half of them had significant immune suppression. So the findings again in the assessment was that disease severity was often underestimated and management was not aggressive enough. Out of the 58 patients who died, only 39 of them had hysterectomies in cases where the source of infection was most likely the uterus. And the guidance is that if you have two organ dysfunctions in a pregnant and a postpartum woman with sepsis, then you need to do a hysterectomy. If you've had one organ dysfunction and the size of the uterus is 16 weeks or more, the uterus needs to come out. And some of the practical recommendations following this assessment was that obviously we do need to be doing hemoglobins and measuring our mid-upper arm circumference. We need to be giving prophylactic antibiotics for all our cesarean section patients, whether it's elective or emergency cesarean section. Monitoring, using our early warning charts to monitor our patients, and raise awareness of using the quick SOFA score, which I talked about, which has those three criteria, and it has implications for mortality. And any woman who's suspected sepsis, we should be aggressive in our initial management, especially within that first hour of assessment. And Prof. Pattinson is one of the authors in this article, and the guidance was that the ESMO sepsis module should reflect these changes. And the maternity care guidelines should also be adjusted to meet the new criteria. So in terms of the key recommendation from the Surviving Sepsis campaign relevant to pregnancy-related sepsis is the aggressive resuscitation, monitoring the patient if she's responding to the fluid resuscitation, initiation of broad-spectrum antibiotics that I've talked about, routinely obtaining cultures, but again, do not delay starting initiation of antibiotics just because you're waiting for culture bottles, and assess and identify the site of infection and perform source control as soon as feasible. So this what I'm sharing with you now was published recently in the Lancet Global Health, and this looked at frequency and management of maternal infections in 42 countries. This was the GLOSS study. And they looked at almost 3,000 women who were recently pregnant or pregnant and had suspected or confirmed infection. And again, the main findings were here was that there were severe outcomes in women that were admitted with suspicion or evidence of infection. And there were severe outcomes, patients requiring invasive procedures and admission to ICU or high dependency unit. And it echoes what I've been talking about, that the finding from the 52 countries was that there was a lack of adequate assessment of vital signs. Delays in antimicrobial treatment was frequent. And most common infections were UTIs, endometritis, chorioamnionitis, abortion-related infections, and skin and soft tissue infections. And again, the finding here was that a significant number of these infections and the complications that did arise were highly preventable. And although women, most of the women received antibiotics, about a third of the women did not receive any antibiotics despite the suspicion of sepsis. Fewer than half had blood samples drawn for cultures. And in general, women who had severe outcomes had fewer invasive procedures to control source infection. Again, similar to the findings from the South African studies, to say less than a third of women who died of pregnancy-related sepsis had a hysterectomy. So I just want to, I know we're in the midst of COVID epidemic, just to alert everybody that we need to be thinking about what is the impact of COVID-19 infections in terms of on pregnancy-related infections. Are we going to start seeing more complications as we go along? And to also take into account the impact of COVID on our HIV program, we're already starting to see women that are coming in with defaulted treatment. Is this going to lead to cases of decreased CD4 count, increased immune suppression, increased susceptibility to sepsis? And just to say in conclusion is that pregnancy-related sepsis is one of those things that we can do a lot in terms of prevention, in addressing risk factors in the antenatal period. Easy things like correcting anemia in patients who are anemic, screening for diabetes in our obese patient, and also infection control. Infection control when we're doing our assessments in our labor wards, when we are doing our cesarean section, giving routine antibiotics as recommended. And what has come up in the literature that I've presented is that in a lot of the times, the initial assessment was deficient, monitoring was deficient, and these led to poor outcomes. And I've also put in here to say, beware of the normal blanching cervix. So everybody talks about putting in a speculum and you look at the cervix. If it looks pink and blanching, patient is unlikely to have any sepsis involving the uterus. And sometimes it may be deceiving. So if the patient has got an acute abdomen, always err on the side of caution. And the management on source control needs to be aggressive. So I know people may sometimes are reluctant to do hysterectomy in young patients, but it may be a life-saving procedure. Thank you very much.
Thank you, Dr. Mnyani. We have quite a bit of time. I'm not sure, I don't see any questions. Dr. Mnyani, perhaps I could ask the question about how the DCST has been going about dealing with this in Johannesburg generally. What systems are available that doctors in the clinics could be a bit more aware of?
Okay, so Prof, I know in terms of management, obviously the crucial initial management in the community health centers is the assessment, stabilization of the patient and referring appropriately. So we have done presentations in some of our facilities, but the important thing again is we need to increase our ultrasound skills. I know almost all our CHCs do have ultrasounds. So as much as you're not going to do the definitive management at that level, is to be able to use the ultrasound and assess the severity of infection. So, you know, when you're referring, you're alerting your receiving facility that I'm sending across an ill patient. So those are some of the things we still need to, you know, extend to our facilities.
Okay. Any questions? Please, if you have any questions to Dr. Mnyani, just put them into the chat group. Any comments from anybody? In terms of the relationship that that the DCST expects from the medical officers at the clinics, may I inquire, you know, how you all have thought that through as the DCST, and how does it function? I mean, one of the challenges we have is that relationship between doctors in the clinic CHCs and the MOUs.
I think it is a challenge, Prof, in taking into account that there's always, you know, competing priorities, shortage of staff, but there is a need to have doctors in the CHCs more involved in the MOU side. And we're not seeing enough of that involvement.
One of the challenges, if I may just ask, and then you can respond to that. One of the challenges is that most of the experience of doctors is that they are never, you know, they're never really called on early enough or involved in the processes, often maternity obstetric unit, until there's a crash and alarms are ringing off. And often our difficulties as medical officers and family physicians is that it's seen as the territory of the midwives and the obstetricians. I don't know how you'd respond to that.
When you say, Prof, they're not called early enough, you're saying in cases of emergencies. So
well,
by the time
they're seen as just the port, or, you know, the last port of call. So they're kind of seen as the doctor when we are in panic. So they're called when the person is literally half dead. And that, I'm saying, is the kind of relationship between the sisters in the MOU and the doctors at large.
So it's definitely something we need to address, is that, you know, the doctors need to be involved early. Obviously, the earlier they're involved, the better. But I think the other thing that we need to be looking at is that I know that doctors in the CHCs are busy, but just to also for them to routinely be part of the MOUs. It doesn't have to be every day, but just to know of the processes that are happening in the MOUs, just management of the obstetric emergencies, because I know if you don't do these things often enough, you forget them. So we do drills in the MOUs. It would be nice to have the doctors join the drills so they know that when they're called out, they know what to do.
Would you not be able to look at that being a requirement that doctors in the facility be part of such activities? Because if you as the DCST put that out as we want doctors to be involved and request that, I think you'll get a lot more happening, and it will be taken as a normal that doctors need to be part of the discussions. At the moment, you're kind of saying it's nice, but it's not something you're asking for or even insisting on. So I think one would need to think that through. And I know as family physicians, we struggle to get taken seriously. And, you know, as doctors go, the sort of reaction is, well, if they don't need us, we're not going to fight to be there. So I think it's, you know, it will be very important to come through from you as the DCST in your processes across the district. Perhaps we can just ask the other question, you know, the antenatal care. You've mentioned some of the key issues. Is there room and possibility for doctors to be part of antenatal care as well? We know that we've, in fact, for the 2-year internship or the 6-month family medicine rotation for 2021, that's starting in January 2021, we've included time in antenatal care and in, child health. So I'm not sure that that's going to make a big dent, but nonetheless, we want to try and find ways in which doctors move through or interns move through, antenatal care. How would we be able to negotiate that? Do you think there are any difficulties?
I don't think so at all, Prof. And that's what I was saying earlier, is that if we can get our young doctors to be familiar with managing pregnant women before an emergency arises, it's better quality of care for the patients. I don't think there'll be anything difficult about that. I mean, our antenatal clinics are busy. There's always something to do. And even learning ultrasound skills. I know it's something that we've talked about, and then COVID happened, but being able to do a basic obstetric ultrasound is a skill that every doctor should have, whether you're going to do obstetrics or not. So it's one of the other things that we need to be looking at. Okay.
Well, that sounds very good. I think that certainly the family physicians would take up some discussions with you and others in the DCST about the relationship. Well, I don't know if there are any other questions.
Yes. Can I ask a question?
You want to chime in?
Yeah, no, I wanted to ask a question about the guideline of in case of severe sepsis in pregnancy, like septic abortions. I've seen Dr. Mnyani giving those guidelines, how to manage them. The place in our CHC where this situation may happen is casualty. Can we not have those guidelines and put on all our casualties, because in waiting to stabilize the patient so doctors can know what to do, and such of guessing and giving whatever they feel that they can give. But I think with this guideline clearly done that this case, to be put in casualty so that all the doctors may know what to do in waiting to transfer the patients.
Thanks, Dr. Manda. Dr. Lembete is on the webinar. I don't see her now, but I was just going to ask her if those have not been put up, because she's been part of the DST longer than me. But we can definitely do that, put up the guidelines.
In casualty in particular?
In casualties, yes.
We're having so many emergencies of that nature happening.
Sorry, Dr. Manda?
I'm saying we're having this kind of emergency quite often, and mostly when doctors, there are 2 or 1 during the night, and we receive that kind of cases, we're just not having a clear guideline what to do, and they can give any type of antibiotics or fluids, like you were saying, that a proper assessment, and we know what you are dealing with, and then transferring those patients. Yeah.
Dr. Mnyani, it might also be useful to create a file for doctors in the MOU, actually, because that's often where the doctors call. And just put all these guidelines into that file, whatever guidelines that relate to emergency care. I think that would be a very good way of supporting doctors who may not be familiar because they don't get into the MOU setting very often. So that might be a useful idea rather than sticking it up in a casualty wall. Does that seem like a useful idea in the MOU?
No, it is, Prof. But again, I think we should emphasize the need for the doctors to join the drills.
No.
Because again,
I think that's a mix.
If you've done the drill, even if you can't remember the detail, when you open the file, you know what you're looking for.
Good. No, that sounds good. So let's take up that process. I think you've talked about involvement in drills, links to the MOU, more regularly and more structured, and then obstetric ultrasound. So I think there's some clear things to take up. Can I ask that you provide me the presentation, and if you have those guidelines on hand as PDFs, what I'll do is I'll put them up on the website web page linked to this this CPD meeting, and people can go and fetch that on it.
Okay. No, I'll do that, Prof. There's also an ESMO presentation on sepsis. I didn't talk about miscarriages. Obviously, septic miscarriages or septic abortion, if it's an termination of pregnancy, is an important contributor to sepsis. Yeah. And again, to say what can be done at a community health care center, what can be done at a district hospital. You know, things like doing an MVA in an uncomplicated, non-septic, non-bleeding patient. An MVA can be done at a district hospital. But in a patient who's septic, you should not be doing an MVA regardless of duration of the pregnancy. So these are some of the things you know, we need to be spreading out. So as I said, I'll share the presentation. Because as you see in a lot of the literature that I shared, the biggest contributor to morbidity and mortality was assessing the patient and underestimating how ill the patient was, and also not being aggressive enough in terms of definitive management, whether it's referring the patient or whether doing the definitive management where the doctors were.
True. I think you've given a comprehensive view on it, and hopefully that'll be useful. So the recording will also be available on that webpage. You can have a look at it together with the guidelines as well as this presentation. Let's hope we can take up this process further and support doctors in the district health service. Dr. Mnyani, thank you very much. I don't see any other questions. I don't know if any of the other family physician registrars would like to make a comment. Dr. Mnyani, thank you very much. If you can just...
sorry, Prof. I don't know if Dr. Lembete wants to comment.
Yes,
I
Dr.
see
Lembete, is she there? I
she
saw
is,
her.
yeah.
Hi. Welcome.
Can you hear me?
Comments, please.
Yes, we can.
And just
okay.
yourself, Dr. Lembete, so that people know who you are.
I'm Dr. Lembete. I'm a medical officer in the DCST, the obstetric diet of DCST. So I'm working together with Dr. Mnyani. When we started, when Prof. Bookman was still around, we actually initiated the thing of involving family physicians or doctors in the clinic rather, in the MOU, so that at least they take part in the MOU, doing the rounds and get familiar with whatever is happening in the MOU and the management of the patients in the MOU. I'm not quite sure why the whole thing died, but we would like to revive the whole thing. And we would also like for the doctors to come and attend ESMO. Unfortunately, ESMO takes people away from work for a long time because it's actually 4 days, but it actually covers a lot of the things that they need in order to be competent in maternity. So yes, we would like to invite doctors to come and join ESMO and also our drills. Maybe we would have to announce the drills when we come into the facilities so that they can at least join, because drills are shorter, but they still cover what they need to know. Thanks.
No, thank you very much. I see Dr. Chumiaki is not on the call, but we'll certainly take this forward and involve them. Dr. Kalula, you're at a CHC level. Perhaps you could just comment on the question of how that relationship was with Dr. Prof. Bookman and what happened. I think Dr. Lembete just said she doesn't know why it fell apart. Dr. Kalula, would you like to comment on that?
Thank you, Prof. Thank you, Dr. Mnyani and Dr. Lembete. I think Dr. Lembete has said it all. The ISMOS, I think, is very long. It takes capacity away from the CACs. I would prefer the second option, to do draws and drills in the facilities. That will be really very relevant, because first and foremost, why MOs don't go to the MOUs is because of those, they need to have that understandings of ESMO. I think it's very critical if we can do it in the facilities, as you said, and it doesn't take away capacity. I would appreciate if Dr. Lembete and the DSD team can organize it per, let's say, facility, mainly the CACs. That will be a very good initiative. Thanks.
Certainly looking at options to do that. Dr. Petkova, would you like to comment before we close? Dr. Manda, you can as well. Dr. Kabir?
Yes, Prof. I just want to comment that we recently received the roster for Obs and Gynae in Baragwanath, so people can use it if people are on the group, the clinical governance group. So the roster is available, and if you need to contact the registrar or consultant, do that. Do it quickly, because sometimes in Obs and Gynae, the time counts very much.
Good. Dr. Petkova, would you mind just sending that to me? That roster, we'll stick it on this list as well.
Yeah, I'll do that. I'll send it on the email.
Yeah, and then I can just put it onto this.
You can circulate it, yeah.
You can see.
Yeah, I think this week or last week I saw that they distributed to us. It wasn't happening before. I think when the message came out for Baragwanath not accepting patients without the arrangement, the list came out.
Yes, I see it now. Don't worry. Is it the Barra Maternity and GOPD consultant?
Yes.
Right.
Yes.
That's fine. So I think the Joburg Clinical Governance Group, I'll just quickly put out the link here. I think that even the interns were still around. I would encourage you to just join it. I'll put out the link so you can find ways to join that link and pick up whatever's happening. So there you have it on the chat group. So click on it now so that you might be able to pick up and join that group and pick up on what's going on. Dr. Moti, anything to comment? Dr. Manda, and otherwise we can close. All right. Dr. Mnyani, thank you once again. Dr. Lembete, thank you. We appreciate your support, and let's hope we can work towards improving the collaboration and ensuring that doctors address important obstetric challenges in the district and improve the outcomes for patients. To all of you, thank you very much. That's it. Enjoy your weekend. Be safe. Bye-bye.
Thanks, Prof.
Thank you.